Good evening, everyone. Thank you for being with us tonight. My name is Matt Matei. I'm a media relations specialist for Geisinger in the Northeast region. And I'm going to very quickly introduce tonight's presenter and then share some great information with you. Dr. Swathi Gowtham is a pediatric infectious diseases specialist and director of pediatric infection prevention at Geisinger. She's also a faculty member at the Geisinger Commonwealth School of Medicine. Dr. Gowtham is part of an infectious diseases physician group at Geisinger that has been addressing the COVID-19 pandemic at the institution. And she will discuss the safety and effectiveness of COVID-19 vaccines with you tonight, the science behind them, and what to expect after your vaccination. She'll also take some time to dispel a few myths regarding COVID-19 vaccines. Afterward, we'll open it up to Q&A, and she'll answer any questions you might have regarding the development, safety, and effectiveness of COVID-19 vaccines. And with that, I would like to introduce Dr. Swathi Gowtham.
Thank you so much, Matt. And thank you, Maggie. I'm gonna share my screen. If you guys, one of you, Maggie or Matt, if you can let me know if you can see my screen again.
Yep, we can see it.
Perfect. Thank you so much. So thank you for the Scranton Area Community Foundation for inviting me, and thank you all for your attendance and your attention. I'm Swathi Gowtham, one of the Peds ID docs at Geisinger. I'm a virologist by training, and I, along with my partners in infectious diseases and pediatrics, and the entire Geisinger medical community, thank you guys for doing your part in helping us fight the pandemic. So today's talk is going to be mainly about COVID vaccine itself and the virus variants that are out there and what that means for you and your safety. So I have no relevant financial or non-financial interests to disclose. I make no money off of the vaccine. And as I said, any views or findings and conclusions don't necessarily represent Geisinger or Geisinger Commonwealth School of Medicine. I'm a very opinionated woman, and all those opinions are mine. I will tell you what is science, and I will tell you what is my opinion. So what we're going to do is briefly discuss the mRNA vaccine, that is the science, and then discuss what is known about COVID-19 vaccination and its safety and efficacy, that is also all science. And discuss the variants and how one can protect yourself from the virus, particularly the new strains that are coming out, also all science. So why mRNA vaccine? So why vaccines in general? So bear with me for 1 second, a couple minutes. I'm going to go through how vaccines actually work, what kind of vaccines we had, and these new mRNA vaccines that all infectious disease doctors are excited about. So the entire job of a vaccine is to give you your immune system a lesson on the bacteria or virus, so that your immune system doesn't have to go through the infection to learn how to fight it. So the entire job of the immune system is to recognize a foreigner from self. So it's supposed to say, that's a bacteria, that's a virus, it doesn't belong in my body, attack. But this is my lungs, this is my thyroid, these are my joints, do not attack. And it's a very specific response that happens. So when the body sees a new virus or a bacteria, it has never seen it before. It takes a while for the body to make that response and learn how to fight against it. Sometimes it takes a week or two, sometimes you make no response, sometimes you make a great response early on. But then there are some people, depending on underlying health conditions and age, that can actually get really, really sick before they can make that good immune response. Because it takes, as I said, it takes a couple weeks to make that adequate response to clear a virus or a bacteria. So, and some people never make that response and they can die from the infection. So the entire job of vaccines is, instead of going through that immunity, or what we call herd immunity naturally, we give a way for your immune system to see parts of viruses and bacteria so it learns how to fight it before it sees the real thing. So what we have here, this is a wonderful vaccine lecture thing that I found on the internet by Cullen Lilly, who's a pathologist, that really illustrates the different types of vaccines that we have. So we have vaccines that are made of killed bacteria, pieces of bacteria and viruses. We have toxins like tetanus toxins that are produced, so not real virus at all, that are made from the toxoid itself, again, pieces of bacteria and viruses, and conjugated protein, again, parts of bacteria and viruses. So these pieces are known as inactivated vaccines. So these are not live virus or live pathogen vaccines. And because they are partial pieces of bacteria and virus, the body sees it and recognizes those pieces as foreign. And it makes these things called antibodies, which are these little upside down Ys that recognize and bind these proteins as foreign. These antibodies act like little air traffic controllers for your white blood cells to say that, oh, look, there's something foreign here. So because it's a killed vaccine, it's a partial vaccine, you get that really partial immune response by making antibodies against that. And what that means is that sometimes cells like T cells and B cells and other white cells that produce memory and long-term memory don't get activated. So this is a very partial immune response. So that's why with killed vaccines like tetanus and pertussis and pneumonia, you really need booster shots to keep getting that immunity and to keep getting those antibodies, because those antibodies will go down with time. So those are killed vaccines that you see up in the first three rows. Then we have live attenuated vaccines. So what live attenuated vaccines are is measles, mumps, rubella, and varicella are the examples of that. So what we do is that we take a measles virus and then we weaken it and weaken it and weaken it, get weak strains of it so it doesn't kill anything in a petri dish. And then we inject that into people so that you get a really weakened virus. So it's not the real virus, so you don't get as sick from it like with measles. But about 7% of children who get MMR can actually get a measles-like rash. It's not contagious or anything like that. And they can get some fevers and stuff as if they have the infection, but it's not a very strong virus. So the weakened virus has an advantage because it gets taken up by the cell as if it's a real infection. And then it actually activates not only antibodies, but also it activates your T cells, particularly the memory T cells. So if you get your 2 shots of the measles vaccine and you're done for a lifetime, so unless, I suppress your immune system by giving you medications, that gives you long-lasting immunity. Because it's almost like a real infection, but without all the bad things that are associated with the real infection. 1 in 1,000 kids with measles die of a brain infection. So people don't know that, and that's why we vaccinate against measles. So that's the reason why this is the live attenuated vaccine is used. So with COVID, we knew the genomics of the virus in January. And by the weekend, per the NIH, they actually developed the mRNA for the spike protein. And if you remember what the spike protein is, if you've seen pictures of this virus, there's like little hubs of spikes that are kind of going on. And it's that protein that the immune system can recognize. And that protein, those spikes are what the virus uses to enter the cell. So it's a very important protein. So we took that spike protein and we made the mRNA of that. So if you again go back to biology, it's DNA and mRNA, messenger RNA, and then the protein. So instead of getting a piece of the virus, the spike protein, we wanted to introduce the step that comes right before that. So if I inject, so it's not DNA of the virus. So the only thing is messenger RNA. And messenger RNA goes into what we call the cytoplasm. So the cell has 2 parts. One is the nucleus that has your DNA in it, and then the cytoplasm, which is outside the nucleus where proteins get made. And so the mRNA goes into the cytoplasm, never enters the nucleus, and then therefore does not change your DNA at all. This vaccine does not change your DNA because it's nowhere near the DNA. So what we do when we inject the mRNA vaccine is that it gets taken up by your muscle cell, okay? And it doesn't go anywhere else. So it doesn't, if you're pregnant, it doesn't go to the placenta. If it doesn't go to any other parts of your body, it just gets injected into your muscle cells. And the cells then will take that up and it then goes into the cell as if the cells take it up as if it's a real virus. And not only does it induce that antibody response, but it also triggers that memory T cell response. So it gives you that memory, we think. Again, we can't prove it because we've only studied it for a few months, but we were hoping that it actually triggers the T cells, and then it could give you long-lasting memory without a live virus. Because again, people are nervous about even injecting weakened virus into people. So this technology of mRNA is not new at all. It was actually, we were thinking of using mRNA to do various things in medicine since the 1970s. But in 2004, we developed the technology to kind of deliver that into cells. And then there are various vaccines under study, including Ebola, but then Ebola went away, because we couldn't study it. But now with SARS-CoV-2 or COVID-19, this technology was brought to forefront again. Because necessity is the mother of invention, essentially. And so what happens is that you inject it into the muscle, it just stays in the muscle, doesn't go anywhere else. And then mRNA is then gone out of your body after 24 hours. So why do we, again, do mRNA is because you can get that cell-mediated immunity response, that memory response, we think, without a live virus, and then you can mass produce this. The amount of milligrams, it's micrograms of vaccine that is required. So a kilogram has 1 billion doses. So you can mass produce this relatively easily and relatively cheaply and quickly. And that is why mRNA vaccines were chosen. So there are 2 mRNA vaccines that are approved for emergency use authorization by the FDA. This came out in December. When I'm going to explain the couple different things about the Pfizer vaccine. So Pfizer vaccine was the first one that was approved, and Moderna is the second one. And before I discuss any of the data, I want to discuss some definitions. So first definition is something called reactogenicity. So reactogenicity, as vaccinologists, we describe is the inflammatory response that you get to a vaccine that causes either local side effects at the site of where you got the shot. So your arm can feel sore, could be a little swollen, a little red, or systemic side effects, meaning you can get fevers, you can feel fatigued and achy and have like flu-like symptoms and things like that. So many vaccines cause that. It is your immune response to something, foreign that was injected. So your immune system's working. Not everybody gets that type of a response, but if you get it, that's not unexpected. And we like to note that in these vaccine trials. And then we look at not only side effects, which is reactogenicity, we also look at efficacy, which is how many people actually get the disease that this vaccine is supposed to prevent in a randomized controlled vaccine trial. So the way that vaccine trials work is that we randomly choose people of equal ages, equal health risk factors. These are volunteers, of course, and they don't know whether or not they're getting a placebo, which is saltwater saline injected into them, or whether they're getting the vaccine. And then the people who are following them don't know, which one they got. And then there's like a couple people up top who are not in charge of giving any of this and who are not in charge of measuring for COVID, who know who got what, that they can then interpret the data. So if you look at this graph, when people saw this graph, infectious disease doctors saw this graph, it made them cry. So this, the x-axis is days after the dose. So this is time. And the y-axis is the number of COVID cases, cumulative incidence of COVID. So the group that got the salt water injected into them, as time went on, they got more COVID, as time went on. And the group that got the vaccine, as time went on, they did not get COVID. So that flattening of the line is actually very nice to see. And so you can see that the group that got the vaccine didn't get the COVID. So this was great. When we saw that, people were literally like, "There's light at the end of the tunnel." And 7 days post-vaccine, 9 people in the vaccine group had gotten symptomatic COVID. So they got symptoms and then got swabbed and tested, whereas 172 people in the placebo group got COVID. So then looking at, this is for the Pfizer vaccine, so looking at the reactogenicity or the side effects from the Pfizer vaccine. So reactogenicity, these symptoms occur within 1 to 3 days after the vaccine dose. They should not include cough or cold. So if you get a fever and cough or cold, that's probably real COVID. You should get tested. But if you just get a little bit of fever and a little bit of achiness without a cough and cold, that's probably related to the vaccine. These symptoms generally resolve after a day or two. And if people really feel like they have fever and they're feeling really achy, the CDC and infectious disease doctors recommend that you take Tylenol or Motrin to help you get through those symptoms. The reactogenicity, that immune response is actually worse in the younger population and after the second dose, because we think that the immune system gets primed, and with the second dose, you get like a little bit of a booster effect, and you get more of an immune response after the second dose. Again, we expect it, and we counsel patients about it. So looking at this, the which is local events, and you see that there's green and blue, which is mild to moderate. So mild moderate means that I'm noticing a little bit pain at the injection site, but it's really not stopping me. Moderate, I notice it, but it doesn't stop me from doing anything. Severe and grade 4 means that it's stopping you from doing something. Grade 4 means you need to seek medical attention to, and that's yellow and red, and you don't see any of that, not that much of it, particularly with local symptoms. And then you see systemic side effects, which is B, and then fever, fatigue, headaches, chills, vomiting, diarrhea, muscle pain, and joint pain. And this is use of antipyretic medications, which is Tylenol or Motrin. And you can see mainly, again, blue and green, which is mild and moderate. Very little yellow. And again, the higher number is after dose 2 and in the younger folks as compared to those greater than 55 years of age. Similar thing with Moderna. Again, the gray line is the placebo, and then the blue line is the vaccine group. Again, the vaccine group doesn't get COVID as they go through time. Again, this is symptomatic COVID. We never tested all these people like every 7 days or every 3 days. We only tested them if they developed fevers or cough or cold symptoms that are consistent with COVID, and then they got tested. So again, symptomatic COVID has been reduced in these two groups. These are the side effects from the Moderna vaccine, local events versus systemic events again. Grade 1, grade 2, very mild. Grade 2, you kind of notice it, but it doesn't stop you from doing anything. And grade 3 is you really notice it stopping you from doing something. And so again, most of it is grade 1 and grade 2 and self-limiting. So how well do we know that mRNA vaccines work? They work quite well, and the data is after 2 months of giving the shots, those slides that I showed before, but these patients are being followed for 2 years. Most of the main side effects that occur within about 3 to 6 weeks after mainly 3 weeks after the shot. So when we got 2 months worth of data, safety data, we as infectious disease doctors felt comfortable that this is great. Like, the safety, it looks pretty safe, but we still like to follow and make sure there's nothing long term. So that is why it is being authorized under the emergency use authorization, because there's a need for vaccine. From the Pfizer vaccine, the EUA was approved on 12/10. It's about 21,000 people in each arm. It's a large phase 3 trial, and Mrna Vaccine is 15,000 people in each arm, so a total of like 30,000 people for both placebo and the vaccine. And the approval for Pfizer is greater than 16 years, and then Mrna is greater than 18 years, and then the efficacy is 95% efficacious and 94% efficacious. So they're pretty much equal to each other. And if you can look at the amount of COVID infection in the vaccine group was 9. So they are like mildly symptomatic versus 172 in the placebo group, 11 for Mrna, 185, again, pretty much equivalent to each other. Severe COVID infection was defined as if you needed to be hospitalized for COVID. That was 1 in the vaccine group and 9, and 0 and 30 for the Mrna. So it really decreases severe and symptomatic COVID disease. That is what we know so far, but more data is needed to figure out whether or not it truly decreases asymptomatic COVID. So if you don't have any symptoms, will it still decrease that? And that data is still cooking. You guys must have heard about this allergic reaction called anaphylaxis that has been reported with the vaccine. This came out by the CDC MMWR in December 14th to 23. Initially 21 cases of anaphylaxis, again, without death. This is a very severe allergic reaction where you feel like you have shortness of breath and your throat feels like it's closing, and hives and things like that. This was reported with the Pfizer vaccine, and at that point, 1.8 million doses were already administered. So it was about 11 in a million doses. In comparison, the flu vaccine is about 1 in a million. And about 71% of them occurred within the first 15 minutes. So for those of you who've already gotten the vaccine, that's why we ask you to wait for 15 minutes to make sure that you're doing okay. So then this was me being me. So I was, when presented with that data, because I had to decide whether or not I needed to get vaccinated because I am one of the frontline people. So I calculated my chance of anaphylaxis was 0.0011% from the vaccine at the time. And then for my age and being a female, my chance of death from COVID vaccine, so I calculated the population of females my age in the United States and how many of us have died of COVID. That data is available from the CDC. And that was 0.0092%. So if I got COVID today, what would be my chance of death? That's what I calculated. So I was at the time 8.4 times likely to die of COVID if I got COVID than I am to get an anaphylactic reaction, again, without death from the vaccine. So that's how I made my decision to get vaccinated. Of course, I saw all that data. But this is no longer 11 in 1 million doses. The new data shows that, within a month of vaccine, this data is from late January, that it's 4.7 in a million for the Pfizer and 2.5 in a million for Mrna. Again, these are not that different from each other. So the 8.4 number goes away because my chance of anaphylaxis is much, much lower. So I'm going to pick the higher number, which is the 4.7. And then that makes me 20 times more likely to die of COVID than I was of getting an anaphylactic reaction from my vaccine. Again, I'm in the younger age group, so I'm not 65 years and older, where there's a higher likelihood of dying for COVID if I get it. So for me, it was more beneficial getting the vaccine. I think I made the right decision because, again, the rates of anaphylaxis are much lower now. So there's a lot of misconception about COVID vaccine. And again, I myself have gotten vaccinated. All of my family has received at least 1 dose because my parents are old and my brother's a physician. And so, I'd recommend it to them that they get their vaccines. The one thing, so I would never recommend anything that I wouldn't put in my own body or recommend to my family members. So the one thing is that this is too fast. So yes, we are kind of seeing an unprecedented speed for vaccine development and distribution. This is actually a good thing. Before, it used to take us years to get to phase 3 trials. And phase 3 trials are trials that are done on tens and thousands of people, like what we've described before. But because of Operation Warp Speed and lots of other issues, removing a lot of bureaucratic red tape, the FDA being in phase 1, phase 2, phase 3, and having that close communication instead of waiting months for the FDA to, after completion of phase 3 to be involved, all those red tapes have gone, and we still have good phase 3 trials. So in the end, as physicians and as infectious disease doctors, we're looking for phase 3 trials, again, trials on tens of thousands of people. My heroes, this is opinion, my heroes are those who have volunteered their bodies so that we can be this confident about the vaccine. So all the volunteers that have participated in the vaccine trials, those are my heroes. And so because we don't have long-term data yet, years worth of data, the data is really encouraging and there's minimal safety concerns to date. Despite that, that's why it's not mandatory. And ethically, we would not make it mandatory because without more long-term data. It is there for people who want it. And it's there for people who make the choice of getting the vaccine. And my job, I feel, as a physician, is to give you guys the right science and the right information so that you feel confident in your decision to get yourself or your family members vaccinated. So I really don't think it's too fast. I think we have a good amount of data. And I think we're in unprecedented situations. And data so far looks pretty good in terms of efficacy and safety. The other thing that I hear is that it will change my DNA or it will cause infertility. So not true. So as I said, the mRNA does not enter the nucleus. It is outside the nucleus. So the nucleus is the one that has your DNA in it. So it does not enter the nucleus at all. So it wouldn't change any of that. And it will cause infertility. Again, it doesn't go to any other cells but your muscle cells, so it would not change your DNA or cause infertility based on the current data. And then if I get the vaccine, I do not need to use PPE or social distancing anymore. That's really not true because we don't know anything about whether or not this vaccine decreases asymptomatic transmission. So we know, like with a lot of other viruses, even before COVID, if two people got influenza, in you, it could give you a little bit of a cold and a little bit of fever. In me, it could put me in the hospital with a really bad influenza pneumonia. So we don't really know whether or not people with mild symptoms, people who are vaccinated can get just mild disease and they can still transmit the virus. So the majority of us who get COVID get very mild symptoms or have no symptoms at all, which is a good thing. But it makes us likely to transmit to those who could get really, really sick. So because, again, as I described in the studies, the people who got tested for COVID after the vaccines were those that developed symptoms. We didn't go around swabbing people every 3 days to know whether or not they still carried a little bit of virus, but they never had any symptoms because of the vaccine. So for example, if I get vaccinated and my 67-year-old father has not gotten vaccinated yet, if I wasn't wearing my mask and protection amongst COVID patients thinking that I was protected, I can still carry that virus and get the virus potentially and pass it on to my father who's not who may not be vaccinated fully. So that is the reason why we still recommend until everybody gets vaccinated, we still, or we have more data to show that it actually decreases asymptomatic transmission. We're still recommending that even if you're vaccinated, to wear your masks and still do social distancing. The other thing is, as I said, not everybody's going to be vaccinated all at once. First of all, we don't have that much vaccines. We also have, young children less than 12 years of age. It's unclear when they will get vaccinated, whether they'll be vaccinated this year or next year. We're not quite sure, so we're waiting on data for that. So because not everybody's going to be vaccinated, they can form pools of reservoir for the virus where there can still be transmission. So we should all be still using masking and social distancing despite vaccination. So some final thoughts. As I said, safety and efficacy data beyond a 2-month period for the Pfizer and the Mrna vaccine have not been published or not yet known. People are still keeping an eye on that, and there's new publications if there's new safety things that come out. Again, as I said with the anaphylaxis, but this is constantly being monitored, and these patients are going to be followed for 2 years from the trial. These vaccines have not specifically been studied in pregnant women, immunocompromised, so meaning those patients that have a low immune system, 16 and 17-year-old adolescents in particular. Pfizer just applied for EUA, and Moderna, I wish Moderna did that as well. But as if the FDA was like, 16-year-olds are kind of like 18-year-olds, so it should be fine. But it specifically has not been studied in that age group. But it really, from the way that we know the vaccine work, is really not contraindicated in these populations. Particularly the immunocompromised patients who have a low immune system. We don't know if they're going to develop that memory and that robust immune response. So I don't know if the efficacy is going to be like 95% in that population, or will it be like 70% or 60%? We don't quite know that. But that means they can still get the vaccine. The vaccine won't adversely affect them. It wouldn't have a bad effect on them. But whether or not it's going to be as protective as somebody with a normal immune system, we just don't know yet. So again, the thing is in yellow. So even if you get the vaccine, please continue to mask, social distance, and do hand hygiene despite the vaccination. The goal of the vaccine is to reduce hospitalization and death. Okay, so that's the goal. So the fact that there's one person, with severe COVID, or 0 people in the Moderna trial with severe COVID, that's a great thing. So whether or not this vaccine significantly reduces, transmission from person to person with mild infection or no symptoms, that just remains to be seen, and we're going to have more data on that. So as I was trying to convince my father to get vaccinated, he said, you're telling me to mask, there are these new variants that are coming up on CNN. What is the vaccine going to do? And literally after, talking to him for like half an hour, I was like, what the vaccine does for you is that if you get COVID, you're probably not going to die, and you're probably not going to go to the hospital. So that's what the vaccine does. So that argument ended up convincing him eventually to get the first shot. So the other thing, I really like this picture. I took it, found it on the internet, and that's the link. I did not come up with it. The main thing about the vaccine, as we as a community think about it, and as we as medical community recommend it, is that we leave no one behind. So yes, we prioritize certain high-risk groups, those that are really high risk of getting hospitalized and being sick from COVID. But we really should target our community education and our mission so that African-American communities, Latinx communities, minority communities, and the poor communities that may have less access to vaccine or less trust in a vaccine, are not forgotten and are not left behind. So looking at the Black and white vaccine rates, only about 0.6% of the, comes from the Kaiser Foundation group. And this data comes from end of January. And only about 0.6% of the Black population in Pennsylvania has been vaccinated, compared to 2.6% of the white population. And this is one of the worst racial ratios. If you're white, you're 4.2 times more likely to get vaccinated for COVID than if you're African American. Again, there are many reasons for that, including mistrust and historical mistrust in the medical community, but underlying discrimination, underlying access to appropriate vaccine information, vaccine safety information, and underlying access to healthcare and vaccination itself may be one of the reasons for this type of discrepancy. So there's limited information as to when and where to get the vaccine, particularly amongst people in general. So in here, as you guys see, when people so this is a survey that was done again by Kaiser Foundation about COVID-19 vaccination. And this tells when people like them would be able to get the vaccine, and people didn't know. 60% of people didn't know. So we're terrible at giving vaccine information in general as a medical community. But if you're African American, Hispanic, you're more likely not to know, 66% and 68%. And if your household income was less than $40,000 a year, you're more likely not to know about where people like you could get the vaccine. I'm sorry, when people like you could get the vaccine, and then where you would get it is also you're unlikely to know, how to get your hands on the vaccine if you are lower income, Latinx or Black, compared to your white and higher income counterparts. So we need to do a better job. Any questions on the vaccines? I'll kind of pause here a little bit. Otherwise, I'll just move on vaccine safety, and then I can address a couple of other things.
There is one question from Judy. She asks, most of the nurses in my office aged 50 received the Mrna vaccine, and whereas you say class 3, she said they look terrible. Does pre-fluid intake help? And I guess an extension of that, is there anything that patients should or should not do, before or after?
Yeah, we don't really know if pre-fluid intake really helps. One should always be hydrated, when there's, muscle achiness and things like that. What really does help is ibuprofen and Tylenol. We recommend that if you get those side effects. Generally, this is opinion. The science is that generally it should last about a couple of days. My opinion is that it's totally worth it. So I was achy after my second dose as well, took some ibuprofen, rested, and felt better after like a day or two. It is self-limiting, and it should go away. And ibuprofen and Tylenol generally help, and it's always good to be hydrated. There's no data that in particular that hydration itself will help prevent it.
Great.
All right.
There's two individuals ask whether or not this is going to be a vaccine that we feel will be occurring yearly or having to get annually.
So we don't, again, quite know. If we're going to talk a little bit about variants and the different strains that are coming out, but we don't know how long the protection lasts. So stay tuned for that. And if there are new strains that are not being covered by the vaccine, then we may need something on a yearly basis. So as of now, the short answer to that question is we don't know. Stay tuned. We need more information.
Great.
Okay.
And then the last question that we've received so far is, do you think that there might be a correlation between the lack of information and the fact that there's virtual schooling happened?
I'm sorry, lack of information and virtual schooling, what?
So that there might be a correlation between the lack of information and the fact that most students are in virtual schooling, that, perhaps they're not hearing it maybe in the classroom.
Lack of information about the COVID vaccine.
Yeah.
I don't know how good of a job we're doing in terms of virtual school, in terms of talking to students about vaccination. But what I meant by lack of information is that there's just lack of access to good information in general within, for example, in the Latinx community. What's the access? What type of vaccine education do we have available in Spanish, for example? When we're targeting some of these high-risk groups. So that's what I meant. So generally, white counterparts and higher income counterparts are looking things up on the internet and things like that. So there's generally a lack of good information, access to good information, lack of access to science, that some of these minority communities and low-income communities have, and the lack of access to vaccine in general. There's transportation issues and things like that. So let's say if I have only few places where there's a vaccine clinic, can a patient get to that without a car or transportation? So that's generally what I meant by lack of access to information. Okay.
Thank you.
Thank you. I'm going to switch to variants right now. So again, you guys probably are hearing about the different strains of COVID, the UK strain, the South African strain, and et cetera. The reason I love this little chart because all these little lines that you guys see are actually the different variants that are there. There has been thousands of different variants, since March, and this is not new. This virus is called an RNA virus, and these viruses mutate. Sometimes these little mutations do nothing, and sometimes these mutations are impactful. So again, variants are not new. I'm going to go a little historically. So there are two main strains that were initially described in March. Again, there are thousands of different variants. The orange one is the Chinese strain, and then the blue one is the Italian strain. So pre-March, the main one that was there across the world was the Wuhan strain, the orange one. And as March progressed, the Italian strain, which was much, much more transmissible, much, much more infective, infected more people than the Chinese strain, basically kind of took over the world. And so the fact that we have variants is not new. Okay, we were expecting this as doctors. So what does this mean? So in September 2020, there was this UK strain, forget the name of it, there's a lineage, B117. UK strain was first notified in September 2020 in south of England, in London area. And it seemed to be more transmissible than the original strain that was transmitting before. So it was initially thought to be maybe as severe as the regular virus, but there's new data to show maybe it's more severe. It's unclear. We still need more data whether or not it's more, we know it's more infectious and can spread to more people, but is it causing more severe disease is not quite known. Current data shows that the mRNA vaccine, both the Pfizer and the Moderna, are effective against this strain, which is great. Great news. The monoclonals, there's some antibody treatments that we use to treat people who have active infection. Whether those antibodies work, it remains unclear because it's the data is so new. This virus is so new. Our PCR test at Geisinger will not miss this virus as a false negative because it's a new strain. Certain PCR tests could miss that, and that was concerning if you had cheaper, other hospitals could have cheaper versions. So not all PCR tests would pick that up, but our PCR at Geisinger would. And then in October, a South African strain was noted. This also seemed to be more transmissible. It would infect more people compared to the regular strain. But it had the current data shows no impact on severity of disease. Again, there's no impact on mRNA vaccine efficacy. So the mRNA vaccine should work for this. The Johnson & Johnson one only seems to be 42% effective in South Africa. And that may be because of the strain. So we have to look at the Johnson & Johnson. Right now, it's still being studied, and there's no approval yet, but that may be something that we as doctors will be looking at. And then in January of 2021, a Brazilian strain was described in passengers from Brazil and Japan, also seems to be more transmissible. And the data show no clear impact on severity of disease. The data is unclear on severity of disease, but there's no impact on the mRNA vaccine, but more studies are underway because it's just so new. One of the things with this is that the antibody treatments that we use for somebody with severe COVID who's admitted, they may be affected. There's some data to show that that treatment efficacy may be reduced for the strain. So these are the three main strains that the CDC is following. It's also following several other strains, but these are the three main strains that seem to be transmissible. So this is, even if it's not causing severe disease, this is still important. As you guys can see, this is from data from new cases. The green is the data from new cases in United Kingdom with the United Kingdom strain. Oops, sorry. The United Kingdom strain. So you see this, the number of cases going up, but then you also see deaths going up, right? So let's say, I'm now making up numbers. So let's say the original strain goes through a neighborhood and infects 100 people. And mortality, death is 1 in 100, like 1% of death. So 1 in those 100 people would die. If the new strain affects 200 people instead of 100 people, and again, mortality is still 1% of that, then it's 2 people of the 200 that would die. So the death rates would still go up, even if severity is not impacted, just because of the fact that more people are infected with these new strains. So this is still important. So the CDC, as I said, is keeping an eye on it. This is a presentation that I gave at Black Scranton Project and GCSOM last Friday. And this data came from February 2nd, and you can see the numbers. About 541 cases of the UK variant have been reported in the United States for February 2nd. And this is the latest data from February 14th. That number doubled. So 1,000 cases of the UK variant. Florida seems to be the number one state with this, but 40 states have been reporting it, including Pennsylvania. So what to do, right? Like protecting yourself and others before and more importantly after the vaccine. It's still important not to let your guard down. So again, how does transmission happen? This is something that we've been preaching from March, right? So transmission with COVID is nuanced. It's not black or white. I really love this table. This comes from the British Medical Journal. The transmission depends on forceful exhalation of the person who's infected and passing it on to somebody who's not infected. And if you're singing, if you're shouting, if you're sneezing, that is worse than speaking or remaining silent. The number and proximity of people, if you're in a closed room with in a crowded situation, that's worse. The duration of exposure, the longer you're with somebody, the classic thing is to say 15 minutes, of exposure. And then enclosed spaces. So if you're in a poorly ventilated area, if you're in a crowded setting, versus when you're outdoors or indoors in a well-ventilated area. So this is, and both people wearing face coverings and contact for a short time, you're in the green. And if there's no face coverings and contact for a prolonged time, no matter what you're doing and where you are, your risk is still pretty high. So I really like this chart because again, there's multiple factors that show transmission that are important for transmission. So how does transmission occur? We know that there's droplet transmission and airborne transmission. So it is from a sick person who's infected or haven't shown symptoms yet, because remember, you're infectious 2 days before you show symptoms, which is what's tricky about this, right? Like, so nobody knows. It would be easy if I knew I had a cold, I can separate myself from other people. I should still do that. But 2 days before I show symptoms, I could be infectious. And that is why we want everybody to mask, because I don't know if I could expose somebody because I may develop symptoms 2 days from now. So the large droplets is like sprinkler. So if I'm coughing, there's large droplets that land because of gravity closer. So that's like a little sprinkler, they would land within 6 feet. So that's where that 3 to 5 feet, like that 6 feet distance comes from because of the droplet transmission. Airborne are these smaller particles that linger in the air for a longer time. So that's kind of like an air freshener. You see these tiny particles that just like kind of linger in the air. That's the spray from the air freshener. And because of their size, they can travel larger distances. So in order to stop that, if this infected person's wearing a mask, and if the other person's also wearing a mask, you're going to decrease the transmission. The filtration is important and it may be of benefit, but the main way that the mask works is that it helps the infected person to keep their secretions to themselves, and it doesn't let the secretions come out, again, if it's fitted properly. And if it covers the nose and the mouth properly. So right now I'm talking and there's kind of little spittle coming out, and if I was wearing a mask, so those secretions would be contained to my face and they wouldn't come out. So that's the important thing. So my mask protects you. Okay, so if I was infected, all my secretions won't come out and release into the air. Again, I feel like I'm preaching to the choir, but this is all of this is still important. People have been coming out, about double masking and all of that stuff. I know Anthony Fauci said, oh, maybe double masking is a good idea. What he really meant was for the community. We knew that cloth masks, 2 or 3 layers are always better than a single layer. So that's what's important. It's more important for the masks to fit appropriately and cover the wearer's face, cover the nose and the mouth and the chin fully, and just not have any gaps so that, again, secretions don't come out. And breathability, all of that is important. So if you need something else to make sure that the mask doesn't slide off your face, that may be where a second mask would be helpful. Or other ways to keep your masks up by changing the way the ties work and things like that are helpful. Breathability is very, very important. You can't, make people tend to be more compliant with our recommendations if it's also comfortable. So wearing 6 masks on top may not be the ideal situation. Just having that good mask, put a nice seal around your face is actually more important than anything else. And adding more layers may make that more difficult and make you more non-compliant with your mask. And for general public and community, we actually don't recommend people wearing a KN95, some of these respirators that have really nice filtration, nice fitting, tight fitting respirators with a mask on it. Because a mask may disturb the respirator fit and actually may create gaps. And also breathability is not easy in a respirator to begin with, and adding those extra layers may make that worse. This little link to the CDC is actually really cute with pictures on how to make sure that your masks work for you in the community. This is the Geisinger website for the vaccine. If you guys Google Geisinger and vaccine, you can get this website as well, but this is just general information. If I can have a few minutes, I would like to tell you guys a story that I found on the internet from this beautiful writer, Dr. Syed Tabatabai. I'm sorry. He's a nephrologist in Texas. I may go over time. I apologize. So he's talking about another physician, a patient. So this is the story. The thought occurs to him repeatedly as he feels the slow rush of air in and out of his lungs. The irony isn't lost on him. He's a pulmonologist, and all he can think about now is how he took every precious breath for granted. He knows where this is going, dying breaths. He'll never know exactly where he got infected with COVID-19. It's a thought that resurfaces now and then, a lingering loose end. He does spend a lot of time being exposed to it as he works in the ICUs, but he is meticulous with his PPE. It begins with a runny nose. The runny nose is followed by chills. He self-quarantines just to be safe. By the time a cough is developing, he has tested positive. The shortness of breath comes on relatively rapidly. He checks his oxygen levels at home and decides he needs to go to the hospital. Being admitted to a hospital he has worked at is a somewhat surreal experience. So this is what it's like. Everyone's wearing their PPE, familiar yet distant. Like space travelers peering at him through the unforgiving void and the safety of their airlocks. He reviews his own chest x-rays and lab data with the attending pulmonologist, which is the lung doctor. He feels confident that he's going to get better. He's over 60, but he's fit and he's in good hands. He can't deny, though, that it is getting harder to breathe. He feels his respiratory rate climb. Have you ever thought about your breathing on a moment-by-moment basis? If you haven't, consider yourself lucky. To have to work to breathe, really work at it with every breath you take is exhausting and terrifying. He's transferred to the intensive care unit. In the ICU, there's a strange tranquility. The landscape isn't alien to him. He knows these machines and these people. He hasn't been put on a ventilator, but he's getting close. One day, he sees his chest x-ray and has trouble identifying healthy lung tissue. God, he thinks. The attending pulmonologist talks to him, his face on a video screen. Things aren't looking good. They're considering ECMO, but his kidney function is worsening too. He feels icy pangs of fear. But he has these things he needs to do now. He suppresses the fear and calls his wife. He goes over things with her, financial details, insurance details, passwords and codes, all the minutiae needed for a life stopped in mid-sentence. She understands what he's saying. She's stoic like him. She takes notes quietly as he takes short, quick breaths. He falls silent and she's quiet too. The truth is he's scared, but he's also tired. He's been in the ICU for several days. He's tired of being out of breath. So he doesn't speak now. He closes his eyes and listens to his wife tell him about his grandkids. Later that night, he has hallucinations. He dreams vividly that his grandkids are playing. He savors these glimpses of his life before, of love. The steady beeps of the monitor bring him back to reality. He watches the nurses move in their armor and is grateful. The thought occurs to him repeatedly as he feels slow rush of air in and out of his lungs. The irony isn't lost to him. He's a pulmonologist, and all he can think about now is how he took every breath, every precious breath for granted. He knows where this is going, dying breaths. But the next day he wakes up and he notices it's a little easier to breathe. His oxygen saturations levels are better. They're able to wean his oxygen down slowly. He eventually is moved out of the ICU to the intermediate unit. He's on the road to recovery. The ordeal had caused him to lose a lot of weight and muscle mass. He goes to rehabilitation for several weeks. Finally, he goes home. About a month later, he's back at work, taking care of COVID patients in the ICU. He tells his story to a wide-eyed nephrologist. This is the author. I watched him later in the day intubating a crashing patient. Only his eyes were visible beneath the mask and the shield. His gaze is steady, once again staring down the monster. I respect his courage. I respect his skill. Most of all, I respect him for who he is. Later, I sit beside him. I know he has gone through something I cannot know. We sit in silence. Finally, he speaks. He says, "You know the question people ask me the most?" I shake my head. He says, "When are things going back to normal?" He shakes his head. I say nothing. He says, there's going to be two groups of people. One group might have a normal again. The other, no normal, my friend, just before and after. I nod, thinking about what he's gone through, what so many people have gone through before, after, and every breath in between. This talk is dedicated to all those people, my patients and others who have suffered and have died of COVID. Thank you.
Thank you so very much for this just absolutely pitch perfect presentation. This is, I know, contains such valuable information, as well as your story, the story you were able to share. We very much appreciate that perspective as well. I cannot imagine it is easier for our providers to go through this. I had a father who went into respiratory failure in ICU and passed away 2 years ago. So I know what he went through, and so I can't imagine going through it alone or through the circumstances that these practitioners have to do. There's only one other question. There has been comments, of course, but I'm just gonna, the one question is, will Motrin, et cetera, impair immune response to vaccine and thereby reduce efficacy? Which I know we've heard a lot about on the news.
Yeah, so there's no data that says that Motrin is going to reduce the efficacy of this vaccine. There was initially some data that came out with the flu vaccine in children, but there's newer data that suggests that ibuprofen or Tylenol would not affect the efficacy of particularly this vaccine and others. The CDC recommends that you don't need to pre-medicate before the vaccine, but if you're feeling symptoms, again, most people do fine. Most people feel nothing. I felt nothing after my first vaccine. It's the second dose. I was like, ugh, achy. But most people feel nothing. And if you don't feel nothing, great, wonderful. But if you're starting to have symptoms, it's really affecting the way you're working and you're starting to notice something, it's fine to take some Tylenol or Motrin. Great. Or ibuprofen.
Great. So, I mean, that's what most of the questions are. People are thanking you all for, the powerful this powerful presentation and the fantasticness of what you've said. I'll also say too, there was a comment about how important it is to continue to wear the PPE, and thank you for pointing that out. The individual says that they screen for COVID at the physician practice, and the response they usually get is, "Oh, I have my 2 shots, so you don't need to ask me those questions anymore." So
Yeah.
yeah, no. So it's still very important.
Yeah, until everybody gets vaccinated, until we have more data to show that this vaccine really decreases transmission, it's still important for us to make sure that we ourselves are not going to get sick if we get vaccinated. We ourselves are not going to die. But what happens, to my cancer patient that I'm going to be taking care of, who hasn't gotten vaccinated yet, my 6-year-old cancer patient, so that's the reason why I'm wearing my mask and still in the grocery store. So.
And then one other question came through, which just says, I seem to repeatedly hear people say that they prefer the Pfizer vaccine because there's fewer problems. Is there any truth to any of that?
No, that they seem pretty similar. The anaphylaxis rates, the efficacy rates, and the side effects seem pretty similar. Current data shows that they're both very similar. The only thing is, whatever first shot that you're going to get, you make sure that the second shot is the same vaccine. So you can mix and match the Pfizer and the Moderna. So that's very important. Whatever vaccine that you're going to get your hands on, either the Pfizer or the Moderna, we personally have no preference. I've gotten Pfizer, my brother got Moderna, whatever, so.
Okay. And then last one is, do you think it's safe to be around other people who have been vaccinated without PPE?
So the CDC most likely is going to come with new guidelines on this. So there are some infectious disease doctors that are saying, both of you are not going to get so terribly sick, So both the shots, 2 shots, and then the second shot is more than 2 weeks later. Although there are no formal guidance from the CDC, but I'm pretty sure it's something like this is going to come out relatively soon. That says that you don't need to mask and social distance with that group. Obviously, when you're in public, with people who have not been vaccinated, et cetera, or not adequately vaccinated, you should still wear the PPE. But there's no formal guidance from the CDC quite yet. It's a lot of opinion from infectious disease doctors. But I'm sure that the CDC will come out with something like this soon.
Sure. Another question's come in, if you're okay with that, and then we'll wrap.
Yeah, that's fine.
She asks, has the CDC extended the window of 4 weeks for the second dose to 42 days? Now, there was discussion about potentially extending that window.
Yeah, there's great data to show the efficacy. I know Geisinger, based on a lot of the national criteria, has extended their duration, and that's just based on data and recommendations from multiple national organizations. Correct.
Great. Well, thank you so very much again. This was, as I said, an absolutely perfect presentation. I think it was important information for a lot of our nonprofit partners to hear, especially when you talk about making sure that we're getting into those hidden populations. Our nonprofit partners are usually the ones in service to these individuals, and so can really serve as an excellent source of information. Obviously no medical advice, but it helps to have somebody who you trust, such as a case manager or other trusted partner to be advocating for vaccination if they're able to. So.
Yep, that's great. Yeah. And then I'll send out, Maggie, the PowerPoint slides to you so that if you want to share with the group, I'm happy to share my slides with you.
Perfect. Thank you so much. Thank you again for giving of your time this evening. And thank you all for joining us for an evening session. We usually do, as I said, we usually do these during the day, but we're grateful to the doctor for, giving up her time this evening. So
thank you all.
Thanks.
Thank you for the invitation.
Thanks.